Welcome on board, everyone. By way of introduction, I'm Anne Livingston and I'm the chair of the Expert Reference Group for the Queensland Government-funded Community Care Smart Assistive Technology Collaborative. I'll be a moderator for today's webinar, and today's webinar is about what impact does smart assistive technology have in improving the quality in community care. This webinar is part of the series of sessions that are being facilitated by Community Resourcing for the Community Care Smart Assistive Technology Collaborative. Those of you who have attended previous webinars, thanks for your feedback, and our continuation of webinars have been designed from this feedback and the requests that we have received through the collaborative. Our webinars are bringing together local, national and international perspectives in research and development, as well as focusing on the deployment of smart assistive technology in the community care sector. We've got extensive links internationally and been fortunate to work with many other groups internationally. You see a few of these on your slides in front of you today. Again, our webinars have representation from every state and territory as well as some international visitors. So I welcome everyone on board. Those of you who have attended previous sessions know that we have been funded by the Queensland Government to bring together an online platform specifically for community care providers who are interested in collaborating on issues and practices related to smart assistive technology. Our project has achieved extensive national and international geographical reach, and this is growing daily. So many of you will also be aware that we have been funded to network and collaborate internationally for this project, and that allows us to bring the wealth of knowledge and expertise to these webinars. Many of you would also be aware that we have been funded for a consumer access filter on the site. Co-design and collaboration concepts were really important for us in developing this area, and we look forward to any feedback that you might like to give us on this enhancement. By way of noting that we need to, at the front of all webinars, note that neither Community Resourcing or the Department of Communities, Child Safety and Disability Services are endorsing or promoting any particular product, research entity or organisation. Rather, our webinars are designed to inform viewers of examples of various smart assistive technologies in deployment and or development, as well as highlighting, like in today's session, leading edge research. As attendees at today's session, and in the interests of recording, your microphones have been muted. But we encourage you to ask questions, and these questions can be added to the question pane on the right of the dashboard on your screen. There'll be an opportunity at the end of today's session to have these answered. As at previous sessions, we've been inundated with questions, so please post your questions early to ensure that we can cover this in today's session. If it's not covered, we'll attempt to take these up with the presenter and post these questions. In today's webinar, we're very fortunate to have a leading researcher, Professor Greg Alexander. And Greg's going to discuss how early warning systems that include sensors and smart assistive technology help elderly people live longer in the community. Professor Alexander has a broad background in human factors, informatics, gerontology, patient safety, and quality improvement. He's specialised in education in health systems, informatics, and gerontology. He's leading a research team that is, for the first time ever, comparing nationally residential care, quality measures, and information technology implementation in funded services. He's also co-leading a large national demonstration project funded by the Centers of Medicare and Medicaid in the US. In this research, himself and his team are implementing a health informatics exchange system and monitoring adoption and use of technology designed to improve communication between different healthcare stakeholders in order to reduce avoidable hospitalizations. These are clearly areas that people in the community care sector are interested around the intersection of technology and quality, and I guess importantly the use of data more appropriately. We welcome you to today's webinar, Greg, and we'll just note that we're just changing over screens now. Thank you, Greg. Over to you.
Thank you very much, Anne. Can you see my screen okay?
Perfect. Thank you, Greg.
Okay, thank you. So, like Anne said, thank you for that kind words and introduction. I'm also a registered nurse, so I'd like to just put that out there so you know exactly what my background is. And I've worked in a lot of different areas in the nurse field, starting with acute care. I've been in the healthcare field since the early 70s, so quite a few years, and have worked across different areas. I'm going to talk about smart assistive technologies and how they improve quality, and this comes from a project that I have in the United States where I'm working with a team of people. If you want more information, you can go to that link on this page. It's www.eldertech.missouri.edu. Eldertech stands for the Center for Eldercare and Rehabilitation Technologies, and we have a center that actually works on issues that I'm going to be talking about today. This is my dad. So I always, he's passed away about 5 years ago, but our mission in our work is to keep older adults functionally active and productive. But while my dad was alive, you can see where he lived. This is in Missouri. It was very rural. He was probably 2 hours from any major city, and he loved living out in the country in the woods. And he had 10 acres with about probably anywhere from 5 to 10 miles between him and anybody else. And so he was very rural. He got cancer. And he still wanted to stay at home. So we had the issue of trying to keep my dad at home in his area where he lived and trying to care for him. And I live about 3 hours away from him, and so do my sisters. So we had a big job on our hands to do that. And but it keeps me centered in my work and keeps me reminded of why I'm trying to do this. It's because of things like this that are personal. And we have personal stories that I'll share throughout this with people, and some images about how our technology helps them stay active in the community. This is sort of my outline, and I'm going to talk a little bit about each of these areas. The first one is squaring the life curve, and if you look at this, along the bottom line, the x-axis is the time. What time is the person's life. So any individual life starts out at the beginning and goes until they pass away. And then functional ability is an area that we're very interested in our research. If you look at the red line, that's the current trend without technology. The green line is the current trend with proactive care, or with proactive technology that helps us keep people, monitor people in the community if they need assisted help. And so what happens is, without technology, the red line, people get sick, they have functional decline that's more rapid until they die, and when they die at the end of their life, these episodes have accumulated so much that they're at a lower quality of life or a lower functional ability. And what we believe is that with technology, that we can intervene quicker, we can provide nurses information about these people that are living in the home alone, and that by that earlier intervention we can do quicker interventions and improve the quality of life at the end of their life. So everybody's going to pass away eventually, but we're hoping that at the end of life that they've had a much more functionally active capacity than people that don't have the technology. We do this with different types of sensors. We've used Doppler radar, depth sensors, motion sensors, bed sensors, and I'll tell you a little bit about those. And then all of that is merged into an environment where, in a community environment where residents are living in a assisted living facility. We call our assisted living facilities independent living facilities because people are living independently, but they're in a location where they can receive some assisted services if they need it. And then the sensors then provide some monitoring, added monitoring that are embedded. And then we have a alert system, an early illness warning system built into this that we can provide alerts as well as fall alerts to nurses and social workers so that they can check out people who are living in these residences. Right now we're working with an organization, it's an independent living facility that's operated and owned by Eldercare, which is a large organization in the United States that provides services. I work at the University of Missouri School of Nursing, and we have a relationship with Eldercare, and they have a facility called Tiger Place in Columbia, Missouri, and that has 54 apartments, and we have just about 65 residents. It fluctuates a little bit, but from the ages of 70 to 100 with multiple chronic illnesses, some dementia, early stage dementia, and Alzheimer's disease, as well as most of them utilize some sort of walker, some wheelchairs. So they're very characteristic of other people that live in other community settings, but we have the opportunity to work within this organization and do research with people that are actually living in the community, which makes our projects fairly unique. So when we look at some of the results that we've had with our project in Tiger Place residents without in-home sensors, so this is residents without technology, stay 2.6 years longer, or 2.6 years, which is 0.8 years longer than seniors in comparable U.S. housing. And the reason for that is because at Tiger Place we provide a fairly extensive care coordination activities with these residents. We're a nursing school, so we provide lots of services, and we do research around the types of services that need to be provided to these individuals that live in the community to try to keep them there. And so with our models, we do find that our seniors stay longer compared to other seniors in similar settings. And those residents, Tiger Place residents that work or live in our facilities that have in-home sensors, they stay nearly twice as long, 4.3 years, over those that without sensors, and they stay nearly 2 years longer in Tiger Place than those without sensors. So you can see that without sensors, people stay longer, and then you add sensors, and they stay even longer. So it's and they you'll find they feel safer as we go through this. You'll find the types of technologies that we're using are things that they feel comfortable, that they feel safer knowing that they're there. These are the types of sensors that we're deploying. We have passive infrared motion sensors. These are actually taken in an apartment of a resident that lives in Tiger Place. We use gait parameters and falls, and we utilize a depth capture motion sensor system that helps us to de-identify the images, but allows us to inspect those, and I'll show you some of those. And we have a hydraulic bed sensor mat that captures quantitative pulse of respiration, and we're also beginning to understand a little bit about restlessness, which is not something that we've been able to capture before. And then we're also working on blood pressure through this mat by utilizing, it's a hydraulic mat, so it has water associated with it. So the important thing about these things is that if those circles weren't there, and that bed was laying down, you would not be able to see this technology. So it's embedded in the living area, and it's not super noticeable, and that's very important to residents. They don't want to be stigmatized by the technology, so we try to embed it. It's not wearable. That's our philosophy. We develop technologies that people don't wear, but are embedded in their environment. this is an example. Early on, we decided to create these images. We got an architect involved in our work, and we decided to create these images that are available on our website so that people that live at Tiger Place, if they have family from far away, family wants to understand how the sensor systems work, but they're not local. We provided a picture of where the sensor systems are, how many there were, and exactly what they can do within the facility. And so this gives us a chance to sort of look at the types of sensors that are embedded there, and where they're located, and how that's going to affect what kind of data that we have. And so you can see that it's an image that's helpful not only to the research team, because each one of these apartments look different, but they also have a different array of sensors in them depending on the arrangement of the apartments. This is one of our star pupils or people in our research projects. This is Eva. She has a congestive heart failure. She is somebody who is so eager to work with us. We love Eva. She's become part of our family, and a part of our team, really. And she wants to be involved in everything we do. She's over 90 years old, and she's just very excited about what we're doing. And she's somebody that we show and we bring up because she keeps us motivated to do what we do. So here's sort of an infrastructure for you sort of tech people to look at that helps you understand a little bit about our decision support system. We collect an array of data from our sensors, and then it's integrated into a data storage unit that's available pretty much anywhere that people are that have internet access. So I'm living here in Australia, and I am getting alerts every day that I can go in and look at and assess people and ask questions about and provide feedback on for our research projects. Helps us to detect health or change or functional decline, and there's an alert manager that we work with our engineers, and the clinicians provide feedback to the engineers about the alerts, and then we tweak those depending on which alert that we're interested in. And that all fits into a web portal or onto mobile devices that helps us provide health change alerts through an email that's given to a nurse, and then the nurse, who is a care coordinator, then can see the resident or call the family or call the physician and let them know about this information. So that's sort of an interesting way to look at our data. This is an example of our email that we use in our health alerts. This is actually a physical alert. This is from March 4th of 2013. It was a nighttime alert. We have different days, different alerts for different times of the day, because that's important when you're assessing people. We have a 14, you'll see time frame in days, 14 days. So we have a sliding window of 14 days or 2 weeks that we've actually determined that that's sort of a key period of time when you can utilize the alert system to recognize early illness onset. So as a person lives with the sensor system, every 14 days, every day it moves a day ahead, so that you got 14 days of data, and it compares that 14 days to baseline data. So you're constantly comparing that resident's data from previous 14 days to the current 14 days, so you can look for changes. And when there are changes, then we initiate alert. One of those alerts is called an increase in bathroom activity. And this is a link to the interactive sensor interface that provides data about bathroom activity. Then once that an individual clicks on that link, then they can go into a submit feedback form and provide feedback about the database, whether they believe that that's a true alert, whether or not there are issues, and how to address that alert, and then add progress note or add a visit note are also links to an EHR. We have begun to build an EHR with this work, but that's not been our central focus. Our central focus has primarily been to get the sensors up and operating. So this is an example of that alert. So if you look at this alert and it's increase in bathroom, and you click on that left link, that blue link says increase in bathroom, this is the health alert that's generated, and this is exactly what you would see. And so what this indicates is, looking down each column, you'll see that very first day is 12/15/10. That's December 15th of 2010, and then that's from midnight all the way to 23:59. So it's 24-hour period of time, and each column represents 24-hour period of time. And if you look across there, you'll see from midnight to 5 a.m., from 5 a.m. until about 7 p.m., and then from 7 p.m. to 11 p.m. Those are the periods of times that we have alerts set up, and we stratified our days by. And so this specific alert was generated on January 1st of 2011 because this individual had nighttime visits to the bathroom. So there was an increase in bathroom activity that occurred in the nighttime, and we would not have known this if we had not had a sensor system in there to be able to detect this. So we had a nurse go in there and find that this person actually had a urinary tract infection, and so we were able to treat that earlier, and then we would have known if the health alert was not embedded in there, the sensor system. This is another example of how our system works. So these are activity data. So I'll draw your attention to the very right of the screen first, where the colored bars are. So you have a white bar with a blue, white bar at the top with a blue bar at the bottom. That is stratified activity levels, going from less activity or no activity with white all the way down to very high activity, which is blue. And then again, you have 3 periods of time. So these segments of time or days are taken from August to September 2009, March to April 2010, and October of 2010. So these are 3 periods of time, and we're looking at activity levels on a patient that has a history of depression. We have algorithms that are able to give us confidence that the person is out of the apartment, because these are people that live independently. They go out and they eat, typically in the kitchen where they or in the dining room where they live. And so this person typically goes out at 7 a.m. Oftentimes throughout the afternoon or early afternoon, and even in the afternoon before dinner, we'll go out and participate in activities or go to lunch. And then in the evening, they're typically out having dinner, and then they're back in the apartment typically by maybe 7 or 8 p.m., and then they're in their apartment until they go to bed at about 11. That's the very first image you see there. Pretty normal activity. Some blues and grays and yellows, so they have a fairly active lifestyle. They're older, so recognizing that, we can tell that maybe they're not as active as somebody would be that's much younger, but they're still active. However, this person, about 6 months after this initial time frame, you can see that there was less time out of the apartment. They were spending more time in their apartment, which is you can see by the yellows that are there. There's more yellows there and more grays, I believe, than in the previous one, but they're definitely not out of the apartment. Also, they have a lot more activity at night. So at 12 a.m., 1 a.m., 2 a.m., there's some nighttime activity by the gray boxes that are in that time frame, and that's a change from previously. So they're much more active in their apartment, but they're not leaving as much, and they're up at night. So then the third box, they're more or less returning back to their baseline. And they're even much more active. There's much more vivid yellows and even greens and blues in that third box than the previous 2. So if you look at the history of this person, we know that they had depression. It was being managed by a geriatric psychiatrist in that first box. The middle box, we found out when we went in to talk to them and noticed this change, and there was an alert that came about that said this person had less activity. We found out that this person had a personal loss, had someone pass away. they were reporting low energy on their assessment of trouble eating and stopped going to the dining room. And then, so we did an intervention, let the geriatric psychiatrist know, and after the intervention, the resident's activity pattern increased, and they seemed to go back to their baseline level. So this is the power of knowing longitudinal data about activity levels for elderly people who are living in the community, because we would not have known this if we didn't have this kind of data. Our interface evaluation, we do interface evaluations. Those are very important when you're doing those, because you want end users to be able to give you feedback about this data, because our goal is to eventually give them access to this data and to be able to allow them to see it and not just have it be clinician driven. We'd like to include family members and residents as much as possible. So we went through, and I led this this part of this project, and we looked at the interface and had different types of think aloud approaches where people looked at the interfaces and told us what they were thinking, and we documented that and recorded it. And you can see the picture up there on the right where I'm talking to one of our participants. This is what an older example of our interface looked like. We used to use bar graphs or histograms to show the motion sensors, and this is motion sensors from a recliner chair. But we've stopped and went away from that a little bit and went back to these density maps, these density maps like this, because we found that they were easier to read. Actually, our users told us that the density maps were easier to read in the interface evaluations that we did. So some of the things that they said in regards to this interface and the evaluation that we gave, these were comments by residents and family members. The family members and residents would look at the data, and they said things like, it appears more time spent in bed because she isn't feeling well enough to get up. So they were actually being able to look at the data, being able to look at the activities that they were involved in, those residents, and they were making correct assumptions to some degree about how they were interpreting it. And clinically, they were clinically relevant assumptions. Interesting to see when bed restlessness happens. Someone may have restlessness before they fall asleep, but sleep fine most of the night. So they were looking at the timing of the restlessness and when the restlessness occurred. They indicated that they were not sure if activity is normal for an individual or an age group. And then there were others there that you can read down through there and see what they say. But generally, the residents and family members felt that it was useful. Residents said they felt safer when they had the technology. Family members were very excited about this. We did come across some interesting issues when we showed family members this. One thing that we found was that some residents do not want their family members to see all their activity levels, and they don't want to share that. Some residents do. So it's not that this is going to be something that's going to be easily deployable. Sometimes you'll run into family issues that were unexpected, and so you'll have to deal with those. But generally, the interpretability is good. And then, of course, we have comments by nurses and physicians. And again, there's an article that's published and available on that Eldertech website that you can go out and get this, that I published this in a journal. And you can find these sort of comments and things out there. But the clinicians found it useful. They were very much more specific than the residents in regards to the values and the sort of the evidence behind it, and you know, their trust and reliability in these data. And but we were able to improve the data and interface and improve the look and the feel of it and how it's used based on these comments, which is what they were for. These are the things that we're really able to detect early: urinary tract infections, pneumonia and upper respiratory tract infections, congestive heart failure, pain, delirium. Low blood sugar is one of those things that we have somebody working on, but that is not something that you're going to see like in an acute sort of evaluation. You would see like maybe something like uncontrolled blood sugars over a period of time. So longitudinally, somebody has diabetes and they're having trouble with their blood sugar, they might have a lower level of activity because they just don't feel as well. It could be related to that type of thing. It all goes back to our early illness recognition model that I showed you before. Some examples of the types of sensors that we're working with. This is our bed sensor. It used to be a air-filled sensor, but now it's a hydraulic sensor. It's got fluid in it, and it's got 4 arrays, and you can see those 4 arrays in the picture. This sits underneath the mattress, so it's not in contact with the patient, which fits with our notion or model of implementation. This diagram that this creates when people are laying on the mattress and the sensor is detecting them is called a ballistic cardiogram. And that's an example of a 10-second strip of a ballistic cardiogram. And when you lay that ballistic cardiogram over an ECG, which is an ECG is an electrocardiograph, that's a normal heart rhythm that we monitor in the hospital, you can see that there's peaks and valleys within the BCG, the beta ballistic cardiogram, and the ECG. And when you line those up, you can tell where the peaks are. So the J peak in the ballistic cardiogram, the far bottom right diagram, the J peak corresponds to the R, and that R is the systolic beat that you feel of your heart rhythm. So we can actually get a heart rhythm rate from that. When we test that, we always try to do validity studies for our work. When we test that, these are some diagrams that show the reliability and validity of our data. We look at the heartbeats from the bed sensor, so the ballistic cardiogram at the top. Then we utilize a finger sensor, which is a pulse oximeter that gives us heart rhythm, or it gives us not rhythm, but it gives us heart rate and tells us when, and an ECG, which gives us heart rhythm. And then we look at the beat-to-beat intervals that occur in relationship to those 2 different ways of detecting rhythm. And when you line those bed sensors and the finger sensors and the ECG sensors up, they're very compatible. So they're very much equal in their ability to detect heart rhythm and heart rate, not rhythm, heart rate. Heart rhythm is actually an area that we have issues with because it changes the diagrams. So we're working very closely with that, trying to detect when rhythms occur, arrhythmias occur. I wanted to show you a little bit about our capturing gait in home depth using depth data. So this is our depth data system, and we have all of these images around on YouTube, and I'm going to show you some images. And basically we've gone through years of trying to understand how to capture depth data and how to utilize Connect systems, which are gaming systems. We utilize them to help us to monitor gait and stride length and walking speed and those types of things in order to predict when falls occur and actually in fall detection. So again, we try to validate all of this work, and the Vicon system is a gold standard system that helps us to measure walking speed and gait, stride time and stride length, and this is one of our physical therapies researchers on the left-hand side, and she's got little stickers all over her body, which is part of the Vicon system. That's why it's so good. It's because you wear these things that are detectable all the time, but that's not feasible for an individual. So, like in an assisted living facility, so we want to utilize Connect technology to help do the same thing, but we want to make sure that Connect works just as well as the Vicon does. So when we line those up, and we utilize our algorithms for detecting stride time, stride length, and stride walking speed, you see that they line up very well. They're very consistent. And so this is good because it allows us to be fairly certain that we're able to measure those things utilizing the Connect technology as good as the Vicon in our assessments. We also have a problem of when people live in independent living, sometimes there are 2 people living together. And in this case, we have two people living together. We want to detect both of them because they're both at risk of possibly falling. And the way we do that is we look at height and speed. Height will give us the variability that we need to be able to measure walking speed, and then the speed is variable enough that it will be able to have two different patterns of individuals. And so this is a pattern that was created from two individuals that were living together. Those individuals were a healthy husband and a wife with Parkinson's, and you can't really tell any differences from this diagram, but if you look at these waveforms that we put together where you have the daily walking activity, the daily stride time, the daily stride length, and number of walks per day, you get an idea over a longitudinal period of time how much they're walking and active in their apartment, besides just the activity data. And so in this situation, you have a healthy husband and a wife with Parkinson's, and you would think the wife with Parkinson's would have the decline over time, but actually what we found was this husband in this use case actually had a decrease in their walking speed and a decrease in stride length, which was interesting because sometimes you find out things that aren't always the same. These are all or what you would expect. So this is a good use case and an example that we tried to point out. The change is not drastic for this healthy husband, but it is something to point out. It would create an alert. What we found when we looked at these in-home gait changes and the ability to predict falls is we found that when you have a decrease in walking speed of about 5 centimeters per second over 7 days, that there's about an 86% probability of falling within 3 weeks. So again, that fits within our 2-week window of looking at when changes are happening. Decrease in stride length of 7.6 centimeters or over 7 days, you have about a 50% probability of falling within 3 weeks. And we published that paper that just came out this couple of months ago in the Western Journal of Nursing Research, and I'm one of the authors on that. So the system is able to predict falls and help us to detect health changes so people can live longer and we can intervene earlier. This is an example of our fall alert using depth data. So this alert looks a little different than our previous alert. One of the things you'll find is that the fall confidence interval, so we mess with that with our engineers. We want to have confidence that what we're detecting is a fall. And so this would say that we have 75% confidence that this person actually fell. That's important because sometimes we detect things that that are not falls, and because people live in their environment, sometimes they throw clothes on the ground and it's not a fall, but it may be detected. What's interesting about this, it gives you the date and the time that this alert generated, and it gives a little video that's a 10-second video that allows us to see what the fall looked like. And I received these here in Australia, and we're able to look at those and assess those anywhere we go, as long as we have good internet activity and we have a password protected system that allows us to detect those. I'm going to show you a little bit of this fall data here. If you'll give me just a second, I'm going to bring this up. I apologize for. So this is an example of what our fall system images look like. So this is a person who does not have a walker, who actually has fallen. I'll play that again. So what you see is they're standing up, bent over, and then they stand up and they lose their balance and they fall backwards. There's somebody in that chair. I don't know if you can see that, but there's somebody in that chair who actually tries to catch them, but they are not able to help them. See them reach out. So this person, one thing helpful about this, and we described in that journal article, is that what we can do is we can see where they fell, how they hit, what part of their body they fell on. And these are types of assessments that are really important when you're trying to do a treatment plan. And they're very important in helping us to understand situations. Here's another one. This is a situation where this was a fall, but it was actually not a fall. It was a dog that was jumping off a chair. I'll play that again. This is, again, another one of those false alarms that we have, and that, you know, we're trying to understand a little bit about these. So we've done a research study trying to understand this issue of, you know, what happens with a person when they fall, and trying to understand these. So if we look at these false alarm rates, in one of our studies that we have, we just are publishing this actually. We have it under review right now. What we find is that some of the false alarms are due to persons being on the floor already. They haven't fallen, they're just on the floor for some reason. Maybe they're working on a project or something. There's an object on the floor, there's a pet, or there's other reasons for that. So what we did is we looked at false alarm sources in Tiger Place. We worked with engineers to sort of adjust our thresholds, and we found that you know, by adjusting the thresholds, we can improve the false alarm rate. But depending on how you adjust it, you can also worsen the false alarm rate. So we looked at 217 fall alerts. 142 falls were detected out of those fall alerts in Tiger Place, and 75 were false alarms. So about 50% ratio were false alarms. And when you adjust the threshold, you can see how many falls per month there were on average there were within the sensor systems in Tiger Place. We had another project where we implemented the technology in other senior housing apartments, specifically in 67 apartments. These were not in Tiger Place, these were outside of Tiger Place. And we learned a lot about how to implement this in the community and how the sensors would work. And you can see we detected all sorts of different problems that were falls. We had a lot more fall alerts that were generated, but we had very few, much fewer falls detected, 67 falls detected and 503 false alarms, which averaged about 1.4 falls per month per person. One of the reasons for this large false alarm rate is because we're working in a community setting, so we're dealing with we don't know the structure of these homes as well. We don't know the setup as well as we do in Tiger Place, so we have a lot more variables to deal with. But you can see the number of days within these 67 residence apartments that we were monitoring was over 10,000, so a lot of days. This is our team. It takes a lot of different types of people to work with. We have a company, it's called Foresight Care. You'll see at the bottom, sort of third person over on the left. This is one of our PhD students. He actually graduated several years ago, and he's leading our organization and is CIO of our company now that is dispensing these sensors. And you can see we have nursing, engineers, social work, architectural studies people, medicine, all sorts of different types of disciplines involved, and that's what it takes. And this is why we do it, because this is actually Marge Skibik, who is one of our lead investigators. These are her parents. They're over 95 years old, and they live in North Dakota, which is a long ways from where we live, and they live with sensors, and they're very active still, and our goal is to keep them happy and active in all their life. And so I'm going to stop there and take any questions.
Thanks, Greg. Really comprehensive presentation. I know a number of people on the line are already deploying in some shape or form some smart home technologies, either in those that are commercially available in Australia or those that might form part of research. I've got a number of questions coming through, but I will remind those in attendance today to post your questions on the question pane to the right of your screen. So while people are providing more, I've got a number already. I guess some of them relate to the issue of data sharing. And you talked about the power of longitudinal data access now that this smart technology is providing you. The questioner asked, did you scope what you can measure and how many data sources you have, as well as do you have a sense of the gaps and what future research might inform about needed data sources to inform particularly direct service delivery?
Yeah, so I'll start with the sort of data points and the areas that that we've built into our system. So the interesting thing about working with engineers is they know very well how to connect data points that are relevant to each other, but they need a clinician to tell them which data points are relevant. So we have utilized the knowledge and expertise of the engineers to look at different types of what we call feature vectors. And I'm not an engineer, so I know just enough to be dangerous about what a feature vector is. But I know that certain data elements have different types of features associated with them, and we define certain data elements, and the way we capture that data, we define that clinically. And so when we look at certain types of feature events like a fall, there may be certain types of feature spaces that we want to capture in the data, like stride length and walking speed and gait analysis. Those types of things are different features, and sometimes you can put a lot of features into a space and get some and connect those data points, and it gives you some really good data that can help you predict changes in that resident's capabilities and their effort longitudinally, their functional ability longitudinally. But it takes clinicians and engineers working together to do that. And so that's one thing and it takes time of getting people together to make that happen. And for it to be clinically relevant, you need that to happen. And so that is one thing that I would say in regards to that question. The second thing is that what is coming in the future. I think that in looking at these sorts of data and these systems, one of the issues that we have in the United States is infrastructure. So, what is the infrastructure that's going to be required to deploy this into independent living settings where older people are going to live, and can we reliably and trust in that data to and will it always work? Will there be, what sort of issues are we going to run into? What is the bandwidth and those types of things? And so we've got a lot of issues with deployment and infrastructure and understanding just basic requirements to get this implemented. And we also have issues of workforce, how the workforce will implement this in their workflow and how they will utilize this data. For example, physicians will tell us that they don't really want to see all this data because it's 24/7. It's a lot of data, and evaluating it is huge. I mean, it just takes time to look at longitudinal data, much like it takes time to look at other types of data. But the thing that they would like to have is they would like to have a care coordinator to look at it and tell them what they see, and then have them go back and sort of double check. So they want to have it interpreted. So a future of this is to look at sort of, one thing we're doing is linguistic summarizations of the data. So we're sort of bits and pieces of language that describe the data in language versus looking at data, longitudinal data, and having those little bits of information be part of that health alert. But of course that has to be described in a way that everybody understands it and would react consistently.
Thanks, Greg. I'll stick with the theme around data and go to the questions that relate to that. You made a comment in your presentation about using or going away from the graphing to diversity maps, and that you found them easier to use. Our questioner asked, did you use other ways of displaying the information? Were there any other formats that you trialed?
Yeah, there was, with every single different type of data that we look at, we really had different systems. So, for example, in our density maps, where we have the density, we've explored different kinds of colors, like for example, red, yellow, and green. Where just like your stoplights, where red would mean stop, notice this is a serious issue, versus yellow, which may be cautionary, and green. We explored a lot of different types of color arrangements. We've done the same thing with alerts in a sense of, trying to stratify the different types of alerts that come along into different categories of acuity. So higher acuity alerts that seem to be like a fall alert that would have a 90% confidence interval might have a red configuration to the color scheme that would help people quickly see that that's probably a fall versus something that was 20%. It doesn't mean they don't check out. They don't have to. They can check out the 20% fall with the 20% confidence, but it's maybe going to be less of a concern for them because of the confidence interval. We've also done a lot of different types of, with the images that I showed you, with the depth images, we've done a lot of sort of mapping those images. So we used to, in the early stages of those images, we used a green, yellow, and a red sort of an image when the image was green, like in an upright format, or when they were laying on a couch, or when the system was not detecting that they were fallen on the ground, then the image would be green. And then as they fell or moved to a position where it appeared to be more confidence that they'd fallen, it would go from a yellow to a red. And so we've played around a lot with those types of things, but every different type of sensor and data input that we have provides an opportunity to visualize it a different way. So
That's
yeah.
great. Thank you, Greg. One of the areas that you mentioned was that you were mapping also the trends around data sharing, and particularly sort of remind you of your comments around individuals' willingness to share data with clinicians slash staff or families. You didn't sort of give a percentage of those, but do you have a sense of how open people are to sharing that data? A number of people on our line, just confronting the rollouts of smart home technology and finding some quite differences between the level of data sharing that individuals want to make, as opposed to some individuals really don't care about who sees their data. Do you have any comments?
Well, I would, out of the 20 or so people that we interviewed, which, that's pretty good for a usability type of study. It's small numbers within that. We've done tons of focus groups and tons of interviews with people about their perceptions of the technology, and there's much fewer people that don't want to share their data than there are that want to share it. So I think it's fairly rare that you'll find a family member or a resident that will not want to share their information with the family once they understand what the data shows. But recognize, that people are people, and older people, I always use this example, whether it's, I don't know if it's politically correct or appropriate, but, older people, you think about older people in their lives, and you think, do they have things in their life that probably are important to them, and being close to other people and those types of things are some of those issues. And so sometimes, if a person lives alone and perhaps have a visitor come over for the night, if you have sensor systems, they're going to detect that. And if somebody knows that they live alone and they have somebody in their apartment at night, there's some information there that they may not want other people to know. So you come across all sorts of different kinds of issues, that relate to what the information can tell us and what's important and valuable for their health and what's just important for them, what they prefer to keep to themselves and what they don't. And we're still exploring that because this is so new. One, it's just allowing them to express their feelings about it, and in a place that is safe, so that they don't feel picked on when, so they'll be honest about it, so that when you're deploying it, you understand what the issues are, the true issues are, and just allowing them a place that they feel confident in sharing truly how they feel about it. It's really important, and it's important for any deployment that anyone's doing, whether it's this type of sensor system or something else.
Thank you. Thank you, Greg. Probably only got one more time for one more question, Greg. Any comments around wearables versus non-wearables?
Yeah, I get that a lot, and I've talked to a lot of people around Australia about that are interested in this issue. And, we have made a conscious decision to not use wearables in our research, and the reason for that is because we feel like wearables are, there's some negatives to wearables, such as, people don't always wear things, and sometimes they take them off, and they forget them, and they're not in a location when they need them. Like if they fall, they may not be able to get to their fall alert button or whatever. But there's also some issues with sensor systems that are embedded in the environment. If you fall outside of that environment, then you're not going to be detected. So it's I think you can think of good and bad of both types of sensor systems, whether they're wearable or not. I think wearables, there are some good applications for those, but we've just chosen not to go there, just because there's so much work to be done in the space without wearables that to work on.
Yep. Thank you, Greg. Thank you for a really fabulous presentation. I think I've sort of got to most of the questions. There's a couple of questions I think that we'll pass on to you for some further comment. But I think your research is really quite groundbreaking, and we thank you very much for presenting to us today.
Yeah, I just want to make sure people are aware, if you go to that Eldertech site where that link is, you will find all sorts of publications and links to publications out there about our work, that there's hundreds of papers on there from back in 2005 when we first started. So it can give you a sense of the different things that we do beyond and above what I spoke about.
That's fantastic. Again, thank you, Greg, for your time today. I just remind viewers of today's webinar that if you already aren't formally registered for the collaborative, the registration details are on your screen now, and we'd encourage you to take the opportunity to register and share that with other people in your organisation. By way of an update on upcoming webinars, you'll see on your screen we've got a number of webinars to be held during May. with looking at different perspectives of the application of smart assistive technology. And register early for those, and we look forward to your participation. In particular, we'd also like to note that we've got two major activities coming up. On the 5th of June, we are supporting the second Australian Living Lab Symposium to be held in Brisbane at QUT, and we'll be sending each participant some further information. On the 6th of June, too importantly, we've got a Community Care Business Transformation and Innovation Conference, again at QUT, and we'd encourage you to register soon, as the early bird registration rate has only got a couple of weeks to run. By way of wrapping up today, I'd like to thank the project team behind the collaborative, the expert reference group members who give their time freely, the Queensland Government for their funding, and specifically our presenter today, Professor Greg Alexander. Thanks everyone for attending. If you need further information from today's session, don't hesitate to email sat@communityresourcing.com.au, and we look forward to your participation in future activities. Thank you.